All right, everyone, we're going to go ahead and get started. All right, so hi, my name is Cindy Simmons, and I'm Associate Director for UC Center Sacramento. Welcome to UC Center Sacramento's last Wednesday talk and symposium on policies to address harmful substance use in California, what works and what doesn't. I would like to, at this time, recognize in the audience our former UCCS Director, Dr. Richard Kravitz, who put together this special symposium for this fall term. I think you are behind this pillar for me. So thank you, stand up. Thank you very much, Dr. Kravitz. I appreciate it. It's been a great symposium, and we've had wonderful attendance in terms of audience numbers. So now to introduce our two speakers for today. So first is Dr. Erica Crable. She's an assistant professor at UC San Diego with faculty appointments in the School of Medicine, Department of Psychiatry, and in the Herbert Wertheim School of Public Health. She also serves as co-director of the Health Services Research and Health Policy Research Program at UC San Diego. She earned a PhD in Health Services Research and an MPH in Global Public Health, both from Boston University. Her expertise is in health policy, health services research, and implementation science. Through her research, she investigates the role of policy and politics in achieving health equity outcomes, specifically looking at opioid use disorder and reversing the overdose epidemic through equitable access to addiction treatment. Dr. Crable's research is funded by the National Institute of Health and the National Institute on Drug Abuse. And our next speaker is Ms. Heidi Steinecker, has over 20 years of experience leading public health policy and healthcare delivery systems. As a deputy director for the California Department of Public Health under both the Brown and Newsom administrations, Ms. Steinecker led public health oversight for the largest healthcare system in the country. Currently, she leads the Public Health Services Government Transformation Consulting Practice for Ernst & Young, where she works on proactive approaches that result in fewer fatalities, greater workforce retention, improved quality and safety of patient care, and increase access to care. She pairs data-driven systems with people-led processes to provide positive transformational changes in counties, states, and countries. Ms. Steinecker also serves as the vice chair for the World Trade Center Executive Board in Northern California with a focus on global health issues. Please join me in welcoming both of our speakers today.
Okay, I'm mic'd, so I don't need that. Thank you. Well, it's an honor to be here. Thank you all so much for spending your afternoon with us. So I am going to talk about the research perspective of supporting evidence-informed policies to increase access to effective harm reduction and substance use treatment across California and in some other places. Just an acknowledgement, I'm grateful for funding from the National Institute on Drug Abuse, and I don't have any conflicts of interest to declare. So I figured we would start by talking about what is the research to policy gap, just do some level setting, make sure we're still all on the same page, talk about its drastic consequences for substance use treatment service access, and note that we actually, as researchers, have a lot of tools to help solve this research to policy gap and make it a little bit smaller. We'll talk about dissemination and implementation science at the intersection of health policy as some tools in our toolkit to address this issue. And I'll give you some recommendations that work in my work to do have more of a policy and use-driven research agenda for substance use treatment. So the research to policy gap, right? I would define this as the failure to translate research findings into real-world evidence-informed policies. And this is important because policy is a blunt instrument. I think we've seen a lot of examples of that recently. It's a blunt instrument for altering access to, but also the quality of substance use treatment and other healthcare services that we access. And it's pretty dangerous to our health systems and population health outcomes when that gap widens. So we need really smart interdisciplinary folks like you in this room who are thinking about the research to policy gap and some tools to address it at big P, like federal and state policy, but also organizational little p intersection. So I'm excited it was great to meet many of the students this morning and hear more about how you're doing this. So the research to policy gap, it's everywhere, as I mentioned. When we have a poor use of research and little p organizational policies, or big P federal state policies, we get low-value healthcare services like unnecessary scans and tests, inappropriate prescribing practices, and nearly 30% of the US healthcare system constitutes unnecessary healthcare services. But what happens when the research to policy gap actually blocks access to care rather than just providing care that you don't need? This is the problem we have with substance use treatment. So across the country right now, this is current data from SAMHSA, we have a huge unmet need for substance use treatment, and this is a consequence of our research to policy gap that you've been exploring in this seminar series. These gaps occur at multiple levels, as I mentioned, to hinder access to quality treatment and harm reduction services. 19% of all Americans ages 12 and older have a need for substance use treatment. These might not be people who are diagnosed with substance use disorders, but they've expressed a need for care. So they're somewhere along that continuum. But of that population who actually has a need for treatment, only 14% received any care in the last year. This means 85% of people needing substance use treatment aren't getting it. But we have a lot of effective substance use treatment services, as noted here. Why aren't people who need them getting access to these services? That's a question that keeps me up at night. We have some gaps closing in California. We're very grateful to live in a state with a lot of innovative policies around substance use treatment. For example, contingency management. It's an evidence-based treatment. You heard about it in, I think, 2 research seminars ago. You heard a presentation about substance use treatments and their effectiveness. Contingency management is one of those. It provides motivational incentives to treat individuals living with stimulant use disorder and support their path to recovery. And it recognizes and reinforces individual positive behavior change. So contingency management, importantly, is the only treatment that has demonstrated robust outcomes for individuals living with stimulant use disorder. But we have some federal policy gaps right now that are not caught up with the science, and they're serving as huge barriers to people across this country getting access to contingency management. The anti-kickback statute, beneficiary inducement statute, and Stark Law are all federal policies that prevent widespread implementation of contingency management and creating sort of reimbursement systems that would support it. But California has used a Section 1115 waiver in their Medi-Cal program to create the Recovery Incentives Program, where we're actually allowing Medi-Cal beneficiaries to participate in a 24-week outpatient program with recovery support services following up with them as a way to test out how well could contingency management really work. And that's important because California used a Section 1115 waiver as a way to sort of circumnavigate some of these federal policies that are blocking access to contingency management in other states. So California is using policies to effectively close the gaps in some areas. California has a record of doing this. It's a state with a really robust history of 1115 waiver use to close research gaps. And just for those of you who aren't super big Medicaid and 1115 waiver nerds like me, 1115 waiver is just a part of the Social Security Act that allows Medicaid agencies some flexibility in the design of Medicaid benefits, eligibility for Medicaid services, and how those services are paid for, as long as they are within the spirit of Medicaid. That's literally what the law says. It's wild. So California has a history of using this waiver to do some really cool things. I want to note that the Drug Medi-Cal Organized Delivery System program was the first substance use care continuum-focused 1115 demonstration that the state pursued a few years back. They were the first to adopt a full continuum of substance use treatment services from early intervention, outpatient, inpatient, residential, and recovery supports that they modeled on best practices set by the American Society for Addiction Medicine. It was really focused on meeting people where they're at rather than telling people to get with the program and go into care that they might not actually need. And because it was so innovative, it actually became a model for how several other states used 1115 waivers to create really robust substance use treatment care continuums. So there's a lot to learn from California about how the state is doing in closing the gap between what we know works and what people actually receive access to. But some gaps are still pretty persistent here and other places. California, we have 56 authorized syringe service programs delivering effective harm reduction programs across the state of California, but 56 isn't enough. Half the state doesn't have access to these services. And there are some challenges about public health preemption, whether or not the state health department can actually tell local health departments that these services are okay to deliver. So this is playing out. Maybe some of you are familiar with the situation in El Dorado County, where they've put a block on syringe service programs there, and that's being taken up in the courts at this point. What that means is that anytime these cases go to the court, they're delaying access to life-saving care that our neighbors need. There's a need for health in all policy evidence approaches throughout policy implementation as well, not just policy formation. So when we take a health in all approach, we're saying maybe this isn't a health policy, but what are the health implications of this policy? I'm not comfortable saying those are just unintended consequences, negative health outcomes, right? Unintended consequences are things we failed to consider up front. And so if we bring a health in all policies approach, we could look at some of these policies that are being passed in California, right? We had the executive order from Governor Newsom this summer to remove homeless encampments with dignity. And while I appreciate the dignity component of it, the fact of the matter is the health in all policy approach would tell us that the research says when you remove encampment closures, we see increased rates of HIV among people who lived there and were struggling with substance use. So when we actually start implement these encampments closures, what does it mean to get people into care where they are? What does it mean to actually support their health needs rather than just clearing a sidewalk, right? These are people's where they've been living and where they've actually been accessing services in those neighborhoods. So we have to think a little bit more about evidence throughout policy implementation as well as in formation phases. Recently, California in the November election passed Proposition 36. You heard it talked about in one of these seminars earlier this year. And Prop 36 increased penalties for theft and drug crimes. But the research shows us that harsher sentences do not reduce reoffending. They do not reduce recidivism rates. And so we have to ask ourselves, what are the implications of this for people who are living with substance use disorders? How do we stop punishing chronic diseases and start figuring out ways to get people into the care that they need? So the research to policy gap has proliferated through weak dissemination plans by researchers when we report outcomes from our studies in jargon that don't make sense or are not aligned with the timely policy decisions folks are making at the federal, state, county, and city levels. When we're not talking to policymakers as partners and thinking about the outcomes that we should be measuring, and when we're overshadowed by special interest groups. And so while I think researchers have helped contribute to the research to policy gap, it could also be partially our problem to solve because we have a lot of skills to do this. One of the first things that I do like to dismiss right away is I hear, if they would just use the evidence. I have students, I have faculty come to me and say, why don't policymakers just use the evidence? We would have evidence-based policies. And I think this is a little bit, I understand the sentiment, I understand the frustration, but it's a little bit naive. Policymaking processes, as you all know, are based on a lot of things. Evidence is one of those if we do a good job as researchers sharing what we know works, sharing the facts. But these policies, as they're being made, are also shaped by finances, political capital, societal values, and personal views of policymakers. Those are really important. So evidence-based policy is the wrong expectation. I think we should be looking for evidence-informed policies and making sure that when we disseminate our evidence from science, it's able to overcome a lot of the barriers that we see, a lot of the competing inputs that we have around cost, constituent values, norms, things like that. We need to be reminded that policy change is often about policy succession, right? What comes next? It's often about policies being terminated. It's often about incrementalism with policymaking. We're not usually seeing huge opportunities for wide sweeping change at local levels. That's looking a little different on the federal level, but at the local level, we don't see huge overturn of policy. So what small incremental changes can we be pushing forward to have more evidence-informed policies? And knowing that policymaking and policy implementing are not linear, right? They're shaped by policy networks and different stakeholder groups who need information from researchers at multiple times throughout the policy decision-making and implementing processes. So we as researchers need to be ready to share information at multiple points in time, not just say, well, I gave it to them once, surely they'll go back to it. We need to play a more active role there. There are some consequences if we don't. We're not doing a great job communicating right now, so we sort of real-time benefit of seeing these consequences. Trust in research remains high. These data are from the most recent Pew Research Center survey on Americans' trust in scientists and political views of science. So trust remains high, but it's decreasing from past years. Confidence in scientists is also decreasing. And for now, the investment in science is still strong. But if trust and confidence continue to decline, we might see lower investments in science. And that has the danger of widening the policy and research gap. I think folks in this room might be familiar with the very famous Kingdon multiple streams framework, where we think about a policy window opening when problems, policy, and politics come together at the perfect time. Sort of an oversimplification, but this framework is great for telling us what happened and what might happen based on what we can observe now. But I'm not really satisfied with that. What if we want to intervene and put scientific information into the policy-making and implementing process? So we need a crowbar. And I think that dissemination and implementation science can be a crowbar in our toolkit here. So with that, I'm going to do some level setting on definitions in case this field of research is not familiar to everybody here. Dissemination science is the scientific study of targeted distribution of information and information to specific public health and clinical practice audience. But if we take it up one more level to a more macro look and say, what is policy dissemination? We could say, what are the effective processes or actions for communicating evidence to policymakers so that it's actually used in decisions that impact our public health? Implementation science has traditionally been at an organizational level and looked at the use of strategies or actions to adopt and integrate evidence-based practices or interventions that will improve population health. But again, if we take it up to more of a macro level and say policy implementation science, we could use those same kind of scientific tools to investigate effective strategies and processes by which evidence-informed policies are actually put into place. So there are some core elements to policy-focused dissemination and implementation science research that would be useful for increasing access to substance use treatment services. We could do a whole course on this. We have PhD programs focused on this area of research at UCSD. So I'm going to give you the highlights. We often start with a substance use disorder treatment care quality gap. We've got plenty of those that I just noted. And when we think about what's the evidence-informed thing that we want to implement, is it a practice that we know is underutilized, like syringe service programs? What is it? Is it contingency management? And then we often use a framework as a tool to help guide our study design and the selection of instruments to know which stakeholders we actually need to engage with to figure out who's in the room when decisions are being had and who's in charge of making those decisions at all different places. What boundary spanning roles are they playing as policies are developed and implemented? And then we design our dissemination or our implementation strategy. It's the how-to of changing practice or changing policy for the better so that it can reduce and close the research to policy gap. While most health policy analysis or evaluations look at the impact of a policy on population health outcomes, and that's really important, what implementation and dissemination science say is, what's going on in the process? Because it's great if we get to the outcomes, but how do we replicate it? How acceptable is the implementation object or the evidence-based practice or the policy that we're pushing forward to people? Is it actually being adopted? So can it actually have its intended population health impact? How appropriate is it for the questions that your neighborhood is facing? How feasible and how much fidelity are you actually implementing this thing with? So those are kind of the process outcomes that we look at. I'm going to illustrate that with an example from some active research that we have going on right now. So I lead a national study that I'm going to talk a little bit about, and it's focused on medications for opioid use disorder. Medications for opioid use disorder include methadone, buprenorphine, and naltrexone. And these are safe, effective frontline medications that are associated with reduced opioid use, reduced overdose, reduced opioid-related morbidity, death, increased treatment retention over time, and overall recovery for both adults and youths when they're available for them. So it's worth noting that every single overdose is a preventable death, and we have the tool, medications for opioid use disorder, to help us get there. But when we look at the Medicaid-insured population, which has a disproportionate prevalence of substance use, we see that less than half of all adults and less than 5% of youths living with opioid use disorder have access to these medications. That's totally unacceptable. We can look at the data and say, is this an acceptability problem? Do people not want the medications? That's not what the data show. So we can say, well, is it a prescriber problem? That's not really what the data show either, especially with removal of the X waiver, which put some requirements on how buprenorphine was prescribed. So what's going on? Policy. So we have 3 layers of policy we need to deal with. At the federal level, we have the Federal Support Act, which was a bipartisan bill passed a while back now, and it requires coverage of medications for opioid use disorder in every single state Medicaid program. And that sounds great because there should be a policy requiring evidence-based care to be delivered. But then we have state policy. I mentioned that every state Medicaid program is a little bit different and they have a lot of flexibility, whether it be through an 1115 waiver or other, in how they actually design what benefits are covered in their states. So states may not really be covering all of these medications, or they may be using utilization management strategies like prior authorizations, reauthorizations, urinalysis, really barriers to accessing these safe, effective medications. And then in most Medicaid programs, they actually contract with Medicaid managed care organizations to administer benefits on behalf of the state Medicaid agency. So you may be a Medicaid member, but your insurance card says Kaiser, right? In those places, Medicaid managed care organizations can reinterpret the benefits set by the state. Whether or not they're supposed to is a different question. Whether or not it happens, it does. It's clear. We've documented it. So what we're seeing is 3 levels of policy making where fidelity to this great evidence-informed policy isn't taking place. So we've got the effective medications, we've got a well-intentioned federal policy, but we still don't have access to medications for our Medicaid members. I want to note that California's done an exceptional job here. We actually do have coverage of all of these medications here, but our neighbors next door don't. And so that's a big deal. So we launched a national survey. We call it the PolicyWise survey. It's funded by NIDA. And we send out a survey to every single state Medicaid program, but also every single territory that operates a Medicaid program. So those are 56 of those. And then we also send it out to their more than 200 Medicaid managed care organizations that they contract with. And we said to the leadership in behavioral health making decisions, we said, you know, tell us, how do you generally use different information sources? What do you trust when you're setting MOUD benefit designs? When you're thinking about what you will and won't cover, what comes, you know, who are you talking to? What information do you trust? What do you not use? And the whole idea here is to actually figure out what's going on and then use dissemination science to tailor some of those strategies to improve their use of research evidence when they set policies. So here's a snapshot of where we're at today with this survey. We have pretty good representation across the US and many of the territories. And the people that we surveyed look like the notes on this slide here. I won't go through all of them, but we're seeing mostly female, mostly white, significant amount of graduate school training amongst these leaders at Medicaid agencies making these decisions, a lot of responses from top agency leadership. And what's most important to me here is the average length of employment is pretty stable. Most people are in their jobs 1 to 10 years, right? We're seeing a lot of people in there for the long haul, and that matters because if you start to understand how they're making decisions, you can start to send dissemination strategies to help close the research to policy gap, right, in some of those decisions. But if we saw a lot of turnover, we might question how we actually do this because we're surveying them about how their agency works, how they work as individuals. So I'm going to show you a snapshot of some of the findings to date. These are really high-level findings and not a glimpse at the whole project overall. We asked this question about attitudes toward medications for opioid use disorder of these people who responded to the survey. And everything in yellow is pretty okay. We're seeing that they strongly agree that medications reduce relapse, reduce crime and incarceration. We're seeing that they don't think that they reward people for using drugs and that they do save lives. That's great. But everything in red concerns me. We've got a lot of sort of middle-of-the-road responses about whether or not medications replace one drug with another or they prolong addiction. And so anytime we see that indecisiveness, that's an opportunity for a dissemination strategy to clarify what these medications and their outcomes really do look like. So I'm using that to inform the content of the messages that we'll send. We also ask them some additional questions about medications. Interestingly, 73% of our sample talk about being frustrated by political disagreement in their state about these medications and whether or not they're allowed to cover. So we know that our dissemination strategies have to deal with that at some point. We also see a large majority think that they want more information. They want to keep up with MOUD decision-making and evidence around it. And that's great because that means they'll hopefully be receptive toward our dissemination strategies. But we see some more concerning information here about views of researchers, and we specifically ask about independent NIH-funded researchers here. And everything in pink should scare you. It scares me. Notice that the scale is not blue, is not all of the time, it's most of the time, and pink is some of the time. So some of the time is the majority response in a lot of places, and we're seeing some of the time researchers care about the best interests of the public. Some of the times we're transparent, some of the times we admit mistakes. That's concerning. It means that we might not be the right intermediaries to deliver research to policymakers. We might need to work with a community-based organization. So then we ask about preferred sources of evidence, and that's exactly what we're seeing. They don't actually want relationships with researchers. They still want the research, but it could be delivered in other ways. We ask about the content. We're seeing a need to really go back to basics and understand the effectiveness of these medications. We don't need more research on that. There's been a ton funded. We just need to be better communicators of that research. And when we ask about format, overwhelmingly we see policy briefs, which most public health researchers are not trained in how to write. There's a big movement to do infographics, but that's actually not what people want. So these results tell us about the medium with which we must deliver our messages. So what we're doing is taking these data and many other data points from our national survey and designing tailored dissemination strategies for different state Medicaid agencies and their territory Medicaid agencies as well, and thinking about how could we actually improve delivery of MOUD medications for opioid use disorder and really communicate science when those decisions are being made about what's included in the benefit or how a utilization management strategy is set. But overall, we need more policy use-inspired research questions. We need timely intervening, not just looking and seeing what was the impact of a policy once it was passed. I'm too impatient for that. Our public health needs are too great for that, especially in substance use. We need to instead study the impact of evidence in the policy formation process. We need to engage with policymakers and policymaking institutions, learn their language, learn the outcomes that matter to them, learn the things that are on their desk keeping them up at night, and match our research to it in meaningful ways. So a couple of recommendations to close out. Work locally. There's a lot going on at the federal level right now. There's a lot of uncertainty there, and I know that that can feel overwhelming. But our local policies impact our daily lives in a huge way too. So take a look at your local needs. What's going on in your county, your city, and don't sleep on your Board of Supervisor meetings or your City Council meetings. A lot of important decisions happen in those spaces. Know the stakeholders who are in those positions. Understand how your local substance use treatment systems work and what services are available or not being available to your neighbors who need these. Be a sentinel. Think about new trends in the illicit drug supply. Xylazine is having a really big moment in a lot of the country. This is a really terrible thing that is in the street drug supply that is causing wounds that are very hard to heal for people. And that's complicating our public health responses because the public health infrastructure we have to address opioids isn't set up for xylazine. So be looking at things like that. Be looking at policy surveillance analysis to identify proposed policies, past policies, ways to intervene there with evidence. And always prioritize equity. Think about what equitable access to quality programming would mean for your neighbors, the cost, location, and populations that need to be served by these substance use treatment and harm reduction services. And a lot of this requires building relationships with policymakers. You know, it's not about a 20-year relationship and you knowing the right person because you went to grade school together. It's more about making those cold calls. I make a lot of cold calls. The worst thing that can happen is someone hangs up, right? Most of the time they just don't answer, but you just keep calling or you find someone else to talk to. And be mindful as researchers about the ratio of your asks to offers. I have a personal rule where I say for every one ask, I offer 3 things back in terms of how could I present you more evidence on this? If I ask you to take a survey, what can I do to sort of train your team about something research related? You got to keep showing up and asking them what outcomes matter most. We have a project in a state right now where our funder wanted a certain outcome measured, but our stakeholders said that's not the outcome that's most important to us. And so we brought that conversation back to our funders and got them to reconsider what they thought was the key outcome to hang their hat on. So don't be afraid of those conversations. We can't avoid getting involved in expanding access to quality substance use treatment because of the politics of it or the optics. We can't tell people that they're wrong. We've got to understand what they're coming from and then use that to fill a knowledge deficit. And my big plea for all of us in public health is please no more myth and fact presentations. Most people, hopefully people have seen these before, maybe not. It's when we say, here's the myth about substance use treatment, but here's the fact. Most people remember the myth. It reinforces misinformation. So no more myth and fact information. It doesn't work. But we also just can't stop with our conferences and our peer-reviewed papers. That's not enough. We've got to roll up our sleeves and start talking to people. So thank you so much. I look forward to your questions after Heidi Steineker's talk, but I'm going to turn it over to her now.
Well, thank you, Dr. Crable. I have to say I'm just in awe of your research and very appreciative to be able to share the stage with her today. As she is a researcher and expert in this space, I'm going to give you a different perspective. I'm going to give you the perspective of someone who has been the policymaker and someone who currently consults policymakers around the world. So you can kind of get a better sense of what's a day in a life and what does that look like when we are presented with research and evidence, and what are the things that are all involved in this space. So that's why I titled this, Strategies to Operationalize, because the reality is you can have the best policy, the best research, but if you can't operationalize it, if you can't implement it, it's just a piece of paper, okay? So I start with this picture here of me in Christmas Day in 2020 in full PPE in an emergency room full of COVID in LA. And because at this time, I was the deputy for public health and running the COVID mitigation strategy for our healthcare system in California for Governor Newsom. And so I spent quite a bit of time thinking about policy. My name was on every policy document. So yes, I had my fair share of fun stalkers and death threats and you name it coming toward me and my kids, my family. And my fair share of media people trolling as well. So what I will say about this is just like we were all hands on deck in 2020 and me spending every single holiday and every weekend somewhere in the state of California being flown by our armed forces to wherever I needed to be, we need to have that same kind of urgency when we're talking about some of these other epidemics that live within the US. And yes, we've got maternal health issues, and yes, we have access to care issues, we've got homelessness issues, we've got all these things, and today we're talking about substance use disorder. So I always like to start with why. I'm a huge Simon Sinek fan. So why behind healthcare policy? And really when we're talking about HHS, or Health and Human Services in the US, I would love to say that our number one thing is to care about every single person, right? That to be healthy and pursue life, liberty, and pursuit of happiness, all that, right? Okay, reality. Reality is this, national security. So health is a national security issue, okay? So my little side hustle besides my daytime consulting job is, as you said, I work with the Department of State on international delegations when we're talking about national security, global health security, because it is a security issue. And so that happens to be a picture of me and the ambassador of Finland the night before we were in the Finnish embassy the night before they got signed into NATO. So it is certainly an issue when we're talking about how do we protect our population while thinking about our allies out there. So economy and supply chain, right? So health, what happens if people are sick? They can't work. If they can't work, your economy goes down, right? If your economy goes down, supply chain happens, right? You don't have toilet paper, you don't have eggs, right? All those things, right? We've seen shortages of many things throughout the last few years. So that's a picture of actually me looking at extra morgue space. And so Well, we came up with the idea of getting refrigerators, old refrigerators, and Costco racks so that we could be able to have enough morgue space during 2020 and 2021, and they were used. Food chain, water resources. You're seeing this right now with our food supply and our water supply and safety, right? When we're thinking about infectious disease and how that chain of events happens, right? Disease migration, okay? And when we talk about disease, even though my background is really how do you implement, policies around the world when it comes to infectious disease, substance use disorder needs to be treated, as you had said. It's a chronic disease, right? It's a disease that we need to also be able to be thinking when we're thinking about healthcare surge, healthcare access, and healthcare safety across that continuum of our healthcare spectrum, whether that's acute care, long-term care, whether it is outpatient care, whether it is availability to medications, where it's availability to MAC clinics, and all those types of things. But currently, the way that we address this from a policy angle is very decentralized. And how do I know that? You follow the money, okay? So currently, if you've got, these are all of the abatement funds and the percentages of abatement funds that were released from all of the substance use disorder lawsuits, right? And here would be what a picture of the United States map looks like if you were able to look at the percentage of funding per deaths per million people, okay? And what we know about these monies, right, that come through to the state, where are they going? They're being decentralized as well, right? So in US, in California, we have 58 counties and 3 local health jurisdictions. So basically we have 61 states within a state. So those funds get decentralized further, which is why this is definitely why her strategy of local is so important. Because when you follow those funds of where those funds are being deployed to be able to help use programs, data systems, supplies, resources, and researchers and experts into these areas, right? It's at the local level. So I'm going to echo what she said. You need to be able to be involved locally if you're going to want to help a global issue, okay? So the value of data and visibility in policy. So whenever I'm making a policy, I need information, right? And there's a variety of different types of information. I need quantitative and I need qualitative. So the biggest blind spot that many of our policymakers have is a lack of real-time data. Like we're talking how many people right now are having an issue or potential issue when it comes to substance use. What's that number? How will I know? How will I know it's in this jurisdiction? How do I know in the entire state of California which area is the hottest spot? Which area is the place that I need to send the most amount of supplies or resources or be able to send emergency type care to, right? How do I know that? I need data. I need real-time data, not data that is stale, not data that is from 5 years ago or a cool project that some researcher did, last year, 2 years, right? That is helpful. It provides context to policy. But what I need is real-time data. And there's a lot of systems that we have still even just in California, that are still done by fax, email, snail mail, all of those things, right? Phone calls, right? And we don't have a lot of things that are automated yet, okay? So there are options here for technology to truly help us define not only real-time data, but what do I want to get out of that? I want to identify the contributing factors. I want to be able to do an analysis of that data to be able to figure out what are the root causes, what are the key drivers, and how can I then design different interventions to be more preventative, more proactive, rather than reactive to the situation at hand. And so in order to do that, I need that data and that analysis so I can understand where are the highest need areas and what are those key drivers so that I can think of, okay, these are the interventions I'm going to use in this space, okay? And that's the same whether you're working with homelessness, substance use disorder, infectious disease, chronic disease. How you skin that cat might be a little bit different, but it's still that same process of needing that data. The next thing is capacity and access matching. So if I were to call 988 today and say that I have a behavioral health emergency or I have a substance use disorder emergency, I need them to be able to tell me where and when I can go right now, and that my insurance, if I have insurance, will cover it. Currently, if I were to call 988 today, it does not do that well of a job of those two questions. And we need to get to the point where we have bi-directional portals. I don't maybe want to call 988. What if I just want it on an app on my phone? Or I want something where I don't have to talk to a human being because maybe I'm of a generation that grew up on an app. It's not my generation, but I know that there's other generations that did that, right? And so we need to be able to access people where they're at in the format and the method in which they like that. And bidirectional is key, right? Because not only if capacity matching to be able to find, okay, if I were to go into an app and be like, okay, this is my zip code, this is my emergency I'm having, these are the things I need to have, and this is the insurance I have or don't have. And it needs to be able to match me. And then I need to be able to go. That's what we're talking about, that kind of level of ability to have that, that strategy operationalized with just, not just policy, but actual action here. The other thing with this is that provides the state or the community entity, the government entity, information around where their highest level of need is. It also provides them information of where to build capacity where there might not be capacity or there might be a healthcare desert. And then last but not least is maximizing the workforce. So one of the lessons we have learned in the last 4 years is that you can get really creative with space, which I gave you the example of, morgue space out of refrigerators. And we can get really creative with supplies, whether that means that we have to beg, borrow, and compete against other countries or states to get supplies. We've done that before. But the one thing we can't replicate in healthcare and behavioral health are experts. I can't 3D print a nurse. I can't automatically just somehow replicate, a medical professional or a counselor or a social worker or anyone who works in the space. So I can, gladly try to build the education and pipeline to build more of this workforce, but that's going to take years. So in the short term, we cannot continue to think that we can be all things to all people in all places at all the time. We have to start to prioritize based off of risk, based off of data, based off of where can we maximize our interventions, and what she had said basically, what's your return of investment, and maximizing that intervention for the most lives saved in the highest risk areas. And again, that takes policy using data and technology and people, all of that sphere together when you're thinking about how you're making that policy. And again, but once you have this beautiful policy and you have this plan to be able to do all of these things, right? It's all about how do you implement it? How do you get people to adopt it? And first you have to start with your own staff, your own people. I used to have 5,000 people who worked for me at CDPH. How do I get all 5,000 on the same page, regardless of what county they live in, right? And part of that is not just, doing it from, you can't govern from afar, right? Like you can't govern from the ivory tower of the Capitol or anywhere else, right? You have to be boots on the ground, or what I like to say, heels on the ground in my case, and spend a lot of time. I spent all of 2020 living and following the migratory encampments of all of the migratory immigration food service workers. Started in Imperial County and went up through the Central Valley for a total of 11 counties and months. And that's the kind of leadership that we need, where it's not just public health sits in their little silo and healthcare sits in their little silo and the community is out here kind of floundering around. No, you gotta have the trifecta, that you've gotta have healthcare, which includes behavioral health. And when I say healthcare in my presentations, I include behavioral health. I don't separate it out, because I'm sorry, if you have an issue with your heart, you go to a cardiologist, right? You have an issue with any kind of chemical in your brain, or you have an issue with any other organ, right? It shouldn't be differentiated, right? It is still healthcare. Okay, it's whole person healthcare. And so, again, that data used to sit in silos. Public health data used to sit in silos. We've now learned to combine those over the last few years. But the piece that's missing for that implementation is community engagement. And that means being, again, local and being with the people, devising plans with the people, talking with the people about what is the best way to be able to reach their community and little subsets and different cultures that live within their community. And that is usually through community-based organizations. It could be through different community thought leaders. It could be from someone, a student like you, who's just sitting there in a community meeting and you speak up in a session. You're the person, right? You don't have to have a special leadership title to be someone who's involved in this. So I like to always show this diffusion of innovation model because basically change management and adoption management works like this. This was devised way back in the 70s, and it was all about like, okay, how do you infuse technology and how do you adopt change, right? But you can actually apply this to different sociology models, different models in public health. It's basically, how do you get people to understand that change is needed and then to adopt that change? And you really basically have this kind of hoop of, you've got kind of awareness and issues that you know you need something. And sometimes people will actually take some evidence-based research from a researcher, or they take a policy, and what do they always say? We'll pilot it, okay? Maybe they pilot it in a small county if you're on a state size, and you see how that does, and you try to scale it up. Maybe you pilot it in a state and see then how you can scale it across the US, et cetera, right? But people always say pilot it, right? But here's what happens with this pilot. I drew a little red line here, because here's what happens, is that if that pilot goes well, what happens to that policy? It gets adopted, it gets scaled, it gets brought out. If that pilot doesn't go well with that policy, what happens too often? It gets scrapped. Oh, it was a failure. Start over. When in fact, usually it might just be, you just needed to tweak it. You just needed to have to rethink it. You just needed to analyze why did it not work as well as we wanted it to work, and then adjust it to be able to move forward. The second crux here of this is, let's say you have a policy that's being adopted. It's starting to work well. It's showing some really positive results. The second part of the crux is up at the top before it becomes sustainable, is that's when it's like, but you have fractions, right? You might have, let's say if it's a state, you might have fractions or different groups. They're like, no, this doesn't work for us. This doesn't work for us. So what happens here? Either one of two things. Either it gets shoved down people's throat and say, no, 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 the masses want this, right? This is the best policy. And then you later get a pushback, which is even worse than if you had just stopped to pause and listen and think about what are they saying that we could maybe tweak this and make it better, right? And this is what that policy should be iterative. Very similar to what you were saying, is that you do small little baby steps, because wide sweeping change policy is not usually going to be the thing that's going to, make societies better over time. You have a whole complex, diverse population you have to serve. So think about policy being iterative and baby steps, and bring the people along with you as you are going. And the role of rhetoric. So I think it's, I just pulled this from actually ChatGPT this morning because I wanted to see, out of curiosity, where do most Americans get their news about health policies as of today? And of course, it's digital devices, right? Digital devices, and it's not print publications. So maybe policy documents are perfect because that's what I want as a policy leader. But the policy leader leads populations. And where do those population citizenry get their information? It's online, it's on their phones. And unfortunately though, what happens with that? You can have large media, most people get it on Twitter or now X, Threads, Blue Sky, right? They're sound bites. Is anyone really clicking on those sound bites to see the primary source and evidence behind it? I would argue probably not right now. Which is why you can see whole movements go into anti-science. It's why you're seeing anti-science out there right now. Because science takes time. Science takes evidence and trial and error and testing and writing it up and making sure that it's peer-reviewed and evidence-based and throw it out there in journals that no one reads except other scientists, right? But someone can send a tweet, and it can go viral, and it can spread misinformation much faster. And so think of that when we're thinking about how do we implement policy and how do we get populations to be on board with how we are addressing substance use disorder. Because even how, we had this most recent election, you can see this play out. And I always like there's a great old saying that says, he who owns the message owns the population. So keep that in mind when you're thinking about how are you going to address policy and get it out to where it's adopted to people. So, and I've actually been in a room, and been in the room where it happens, where we have thrown this exact chart on the board. Because when you're trying to eat an elephant, an epidemic elephant as big as substance use disorder, or as big as a massive chronic disease, or homelessness, or infectious disease, whatever, you have to be really thoughtful about how much money you have, how many resources do you have, how much time do you have, and what is the easiest path to help the most amount of people. So it's basically, this over here is your easy to achieve and high impact. Of course, that's your low-hanging fruit that people talk about, right? That's a no-brainer. You're gonna go after that first. Down here is your hard to achieve, high impact. That's what people will say, those are our long-term goals. That's our North Star, that's what we're aiming toward, but that might take a year, that might take 6 months, that might take going through a whole, Senate or legislative hearing, right? That might take a lot more work. And then over here, you've got, okay, this is really low impact. It's high competition. It's really difficult to do, but it's a low impact. It's not going to give you a lot to help people in the population. And then, of course, the other corner here, which is it's low impact, but it's also easy to do. So it's a nice to have. So if you need an easy win, maybe you throw that up there. So when we do policy strategies, discussions, and brainstorming, we literally have been in a room where we will take all the directors of a government and say, all right, throw up all of your ideas onto this wall based off of we're trying to solve this problem. And you map it out and you have that discussion, and then that's how you start to kind of prioritize your dollars, your funds, what you're able to do, where you're able to move. Now, not everyone does this, but I can say that I have certainly used this, and it's helpful to help navigate as you're trying to build policy for something that's really complex and might take iteratively multiple steps to get to where you want. It might not just be one policy document. It might be, 5 to get at different angles of a complex problem like substance use disorder. And in the substance use disorder world, what I would say is these are some of the main stakeholder engagements, right? Going back to the people part. You can have the best tech, the best app, the best, way for people to get the information. But again, you have to have that face-to-face or Zoom-to-Zoom, kind of meat of the people part. Because policy is built at the speed of trust and the depth of need. You cannot build policy and implement it well if you don't have trust and there's not a deep, desirable need from the population that you're trying to work with on that policy, okay? And so obviously we have our government, we've got healthcare, and we've got local leaders. And again, that goes to that trifecta of those 3 entities have to build relationships. And they have to build relationships not just when there is the crisis, but all the time. It has to be part of just their daily job, their weekly meetings, their weekly coffees, or whatever they're doing together to build that relationship. Because I can tell you from someone who was evacuated and had to evacuate and repopulate certain healthcare facilities throughout our state during wildfires and earthquakes, that then later on, when it came to have to work with county leaders during the pandemic, guess which counties already worked so well and collaborative with? It was the counties that had already had multiple wildfires, because they already built the relationships over years and years and years out of need. They already had trust. So they were able to scale up different policies and be able to implement things much faster than the counties where the healthcare leaders didn't ever talk to the government leaders unless it was just like their regular meeting. So relationships are not just something you manage, they are your lifeblood of policy. So if you remember anything from what I've shared today, it is that it's not what's on paper, it is the relationship that matters more than anything else, especially in the area of substance use disorder policy and implementation. So what can we do? What would be my message for you all going next? So tech, we do need tech. We need better tech to amplify the research. And we need to be able to amplify that research as fast as an X or a tweet or whatever you want to call those things now in social media can. So you need better tech, not only for, again, data visualization and real-time analytics of what I want to be working with as a policy leader, but also if I'm a policy leader or if I'm a researcher, I need to be able to disseminate my information in the method in which the public, a public person with maybe a 6th grade reading level can understand and translate it. And if that's not you, if you know that you're not that person who can translate what it is you do, find someone who does. Try it even on your family members. Try to explain what you're researching to one of your family members who knows nothing about your topic and do it in less than 2 sentences and see if they understand it, okay? Got to do it in 100 characters or less, okay, in order for someone to really get it. Focus on trust, again, the people, the relationship, and the policy. You've got to be able to understand how would you explain that policy in a rhetorical narrative. So I shared earlier today with students that my background before having a 25-plus career in healthcare and public health, it was based on, I used to teach rhetoric. I used to teach logos, pathos, and ethos. And I would teach that to AP English students. I would teach it at UC. And the reality is, it's all that. If you can explain your policy, showing them facts, which is logos, showing them pathos, which is the passion, how does it actually affect someone emotionally, and with ethos, meaning credibility, you've got the evidence-based research. If you can do those 3 things in a 2-sentence message to explain what your policy does, then you're golden. So if you can work on these 3 things as you kind of move on and you think about how we disseminate policy in this space. And that's it from me. So thank you very much. We'll be taking questions.